The relationship between optometry and ophthalmology has really grown, and there's a lot stronger ties than it was certainly when I graduated from university. So it's really great to see. And in fact, we were at an event last night hosted by the local ophthalmologist, which was a continuing education event. And part of that is making sure that we're making good quality referrals. Certainly times where there are certain cases where these guys are so busy that they just don't need to be seeing some of the simpler cases that we can kind of manage. But certainly we're often the first point of call to help make a referral with someone starting to develop cataract. If there are other sort of medical episodes at the back of the eye, yes, look, this is macular degeneration. Now you need to see the eye specialist to start looking at whether treatment's something that you need, and it's going to help you maintain your sight for longer. If we detect someone who's suspected of having glaucoma, then again, that's going to be the first point of call is sending them to the ophthalmologist for a workup. So certainly they're that next tier when it turns into something medical that needs a surgery or a pharmaceutical sort of management, then that's certainly where we're going to be sending them.
And even something that's elective, like LASIK surgery. So people should see their optometrist first, and find out, make sure that it's actually something that they're suitable for. Is that right?
Yeah, and look, there where the line is too, that if someone's going off laser surgery, an example, they need to be stable in their prescription. So if their prescription is not stable, then they're wasting their time sort of pursuing that until their vision is stable, and that's something we can be monitoring rather than having to head off to the ophthalmologist to do that. Something as simple as just whether your prescription's stable or not, certainly well within our wheelhouse at managing. The same goes for cataract as well. It's a matter of monitoring it to a stage where that it's now worthwhile having that discussion with the ophthalmologist.
And like when we think about ophthalmologists, it's not just scalpels and lasers. They also have a role with when it comes to actually administering certain types of medicines and drugs, don't they? I mean, I think that optometrists in Australia are still somewhat limited in the types of medicines that they can administer.
Oh, absolutely. So some of the stronger ocular medicines then only available to ophthalmology, and then ophthalmologists, medical specialists, and so they've got the ability to prescribe oral medications where it's suitable for the treatment of that patient. They can start organising hospital admissions. They can start organising medical imaging, and that's something that's limited to optometrists. So certainly if we get to a stage where we think that medical imaging is needed for some sort of vision problem or eye health problem, then ophthalmology is going to be something that we're going to be seriously thinking about.
Okay, well, in the case of somebody, let's say, for example, with keratoconus, what would their journey look like? From the point where they've only got mild keratoconus through to more advanced and then severe. Would they could they come to an optometrist in the early stages and get quite a decent solution there? Like at what point do they need to actually be referred to an ophthalmologist?
Look, I'm sure that's going to vary on who you talk to, but with the ophthalmologist I work with from a keratoconus point of view, I'm getting the ophthalmologist involved fairly early, particularly if I've got a young person who has who have discovered keratoconus. We've got to kind of get a sense of how quickly that's progressing, given that the ophthalmologist is going to be the one who might do a cross-linking treatment. Then if I was the ophthalmologist, I think from their point of view, I would like to have my own data on progression because I'm the one responsible for doing the treatment. So there's a two-way street there. Had a case recently where I had a young patient of mine who'd been seeing for 10 years and he's now starting to develop keratoconus. And so I referred them off to the ophthalmologist to get that early kind of diagnosis. They've also got some instrumentation that looks at that it's able to measure eye shape a bit differently to what we've got, and so you get this alternative perspective to what's going on, and that way they're in there early, and I can now go back to monitoring it and be more accessible to the patient. And if we see any significant change, then you can go back to the ophthalmologist, and the ophthalmologist has already got some good baseline data to go with.
I had a conversation with another optometrist some months ago about cataracts, and he was saying that in his early on in his career, he feels as though he admits he was probably a little too quick to refer patients to the ophthalmologist because they had early stage cataracts. But actually, I think that are there things like, is there a lot that you can still do for patients with cataracts before they get to the stage of requiring surgery? I mean, are there things you can do with lenses, contact lenses, well, yeah, spectacle lenses, that sort of thing?
Look, with some some of the changes in how clearly you see with cataract can be improved just by changing your spectacle prescription. There may come a time where those changes in spectacle prescription don't add up to a significant change in your vision, and so then it's just around those sort of expectations of saying, okay, well, do I feel that this is, do we have an understanding that this is at a level that an ophthalmologist feel that it's medically necessary to remove the cataract? And so some of it comes down to education a lot of the time. So changing prescription where we feel like we can make a difference, a lot of the time it's just educating the patient on where they're at and sort of maybe bringing forward some reviews and just watching it carefully. Yeah, so it does hit a point where sometimes and that's often a signal where you might make a referral where you've got some vision loss that just is not being corrected by glasses anymore.
Right, right. There's only so much that lenses can do for you in that case.
Yeah, and that's where you've got to be really careful that you might measure a change in prescription, but you've got to be really careful at coaching the patient on how much difference this is actually going to make, and it's definitely demonstrating the difference and letting the patient make up their mind on whether they feel that's a significant change, them or not, rather than making the decision for them.